Welcome to the Deep Dive. If you're expecting, you know that while pregnancy is incredibly exciting, it can also feel like navigating a medical maze. There's just so much information thrown at you, and honestly, it's easy to feel overwhelmed. Today, we're cutting through that noise. We're going to take a thorough look at what an uncomplicated pregnancy truly involves. From those very first doctor's visits to understanding key diagnostic tests and even managing those common discomforts along the way. Our goal here is to give you the essential insights you need so you feel informed and empowered throughout this amazing journey. Our source material for this dive comes from detailed medical education resources, so we're getting a really comprehensive, almost behind-the-scenes look at prenatal care. Okay, let's unpack this. We're starting right at the very beginning. That first prenatal visit is clearly much more than just confirming a pregnancy, isn't it? What's the real goal of that initial deep dive into someone's health?
You're absolutely right. That first visit is foundational. It's really about building a complete health story. We go through a really comprehensive health history, looking at your pre-pregnancy health, things like your typical diet, exercise habits, any medications. And that includes over-the-counter, prescription, or even herbal supplements. We often advise against many herbals just because their effects aren't always clear. For instance, common pain relievers like NSAIDs. Generally avoided, they can cause bleeding. But acetaminophen, like Tylenol, that's typically fine.
Okay, so avoiding certain common meds is key.
Definitely. We also delve into your surgical history, like knowing about past spine or cervix surgeries. That could impact options like epidurals during labor. And it's vital to understand any existing health conditions. Things like viral infections, diabetes, which can affect kidney health, high blood pressure, heart conditions, thyroid disorders. These can all influence fetal growth.
Right.
Bleeding disorders, for example, they naturally pose a higher risk for miscarriage.
That makes sense.
And of course, a thorough review of your current medications is crucial. If you're on birth control, that needs to stop. Any IUDs, they have to be removed. We also gather your gynecological history, your last PAP smear, age of menarche, past infections, menstrual cycle patterns, contraceptive use, and importantly, your obstetrical history, any previous pregnancies.
Wow.
Even your occupation can play a role, like if your job involves potential exposure to chemicals, maybe like housekeeping or certain industrial jobs.
That's a lot of ground to cover.
Yeah.
But it makes sense. You're building this complete picture, sort of the landscape of the pregnancy from the start. Moving from that detailed history to the physical assessment, for me, the aha moment would surely be hearing the baby's heartbeat for the first time. How early can that actually be heard? What are you listening for?
Oh, yeah. Hearing that first fetal heart tone is truly a milestone. We can often detect it with a Doppler, sometimes as early as 10 weeks. And then by about 16 weeks, a phattoscope can sometimes be used. We're listening for a rate typically between 110 and 160 beats per minute. That's the normal range.
110 to 160. Got it.
Another crucial measurement is fundal height. This is literally measuring in centimeters from your pubic bone, the symphysis pubis, up to the top of your uterus, the fundus. The general rule of thumb is that 1 centimeter roughly equals 1 week of gestation. It helps us estimate the baby's growth and gestational age.
Okay.
There's normal variation. About plus or minus 2 weeks is considered okay, and it's most accurate between, say, 20 and 37 weeks.
So it's a good tracker for growth.
Exactly. And beyond these specific fetal things, a complete maternal physical assessment includes checking your vital signs, height, weight, thyroid, heart, and lung sounds, and also a pelvic exam to assess the musculature, the size of the uterus, and check if the pelvis seems adequate for delivery down the line.
It's clear that this care goes far beyond just the physical aspects. Pregnancy is such a profound life event, it must affect so many parts of a person's life. How do you address the emotional and social elements?
Absolutely. The psychosocial history is, well, deeply important. We explore your emotions, excitement, sure, but also anxiety, maybe even ambivalence. Those are all normal feelings. We look at your support systems, immediate family, extended networks, and assess their stability. Economic stability is also vital. Do you have adequate housing? Can you meet daily needs? Transportation? Can you manage medical expenses?
All really practical, crucial things.
Right. And importantly, we discuss any cultural preferences or practices you might have, things you want to incorporate or avoid during the pregnancy or birth. It's about understanding you as a whole person, not just, a medical case.
That holistic view is absolutely key. Now, here's where it gets really interesting for me personally. The first round of lab tests. What surprising insights can a simple blood draw or urine sample offer right at the start?
Oh, lab tests are incredibly insightful. A complete blood count, the CBC, that can flag risks like anemia, often iron deficiency, which is really common in pregnancy. It can even give clues about potential preeclampsia later on, maybe showing up as a low platelet count or sometimes falsely elevated hemoglobin and hematocrit.
Okay, so it looks ahead too.
In a way, yes. Blood group and Rh typing are essential. If you're type O or Rh negative, your baby could be at risk for incompatibility issues. For Rh-negative mothers, we give a medication called Rogem. It's an injection given during certain situations like any prenatal bleeding, abdominal trauma, routinely around 28 weeks. And then again, within 72 hours of birth, if your baby turns out to be Rh positive, it prevents your body from forming antibodies that could affect future pregnancies.
So it protects future babies.
Exactly. We also briefly check for ABO incompatibility if mom is type O and baby is A, B, or AB, but that's usually managed after birth with checks on the baby's bilirubin.
Gotcha. And what about infections? I know there are specific ones you screen for.
Yes, we screen for a group often called torch infections. TORCHT is for toxoplasmosis. You can get that from undercooked meat or cat litter. That's why we often recommend pregnant individuals avoid cleaning litter boxes.
The cat litter advice.
Okay. O is for other infections, often hepatitis B. We check your status. Ideally, you'd get the Hep B vaccine series before pregnancy. R is rubella or German measles. We check your immunity with a titer. If you're not immune, you can get the vaccine after delivery, but not while pregnant.
Right, because it's a live vaccine.
Precisely. C is cytomegalovirus, or CMV. It's common, especially around young children in daycare settings. Prevention is mainly avoiding exposure. And H is herpes simplex virus, usually HSV2. If you have active lesions during labor, a C-section is usually recommended to protect the baby. Sometimes medication like Valtrex is given near the due date to help prevent an outbreak.
Wow, that turret screen covers a lot.
It does. And then there's the urinalysis. It gives us a ton of information. We check pH, specific gravity for hydration, but really key things are glucose, if it's spilling into the urine. It might signal gestational diabetes if blood glucose is over about 160. Protein is another big one. A trace is okay, but higher levels, like +3, can be a sign of preeclampsia.
Okay.
We also look for white blood cells or nitrites, which can suggest a urinary tract infection, and this is critical. UTIs, even if you have no symptoms, are a leading cause of early delivery, so we treat them regardless if bacteria counts are high on culture.
That's huge. Treat even if you don't feel it.
Absolutely. And the urine test can also include toxicology screening for illicit drugs.
Wow, okay. That initial visit really is comprehensive.
Mhm.
So once that foundational visit is done, what does the rest of the pregnancy journey look like in terms of follow-up appointments? How often do you typically see your provider?
Yeah, the frequency follows a pretty standard pattern, designed to monitor things more closely as you get further along. Typically, you'll see your provider every 4 weeks for the first 28 weeks. So through the first and second trimesters, basically.
Okay, about once a month initially.
Right. Then from 28 weeks up to 36 weeks, it usually steps up to every 2 weeks.
More frequent then.
Mm-hmm. And finally, from 36 weeks until delivery, it's usually a weekly check-in.
Weekly at the very end. Makes sense. What happens at these follow-up visits?
Each visit builds on the last. We always cover key elements: ongoing teaching and answering questions, checking in on your emotional adjustment, how you're feeling about becoming a mother, and then the physical checks, vital signs, weight gain, assessing nutritional status, measuring the fundal height to track growth, and crucially, checking on fetal movement. That first feeling of movement, often called quickening, usually happens around 20 weeks. It's often subtle at first, maybe felt at night when you're resting.
Quickening. Okay.
We ask about movement patterns, and of course, we always listen to the baby's heart rate at every visit.
Empowerment comes from knowledge, definitely. Especially knowing when something might need immediate attention. What are some of the key danger signs of pregnancy that expectant parents should be aware of? Not to cause anxiety, but just for awareness, right?
Exactly. It's about being informed, not alarmed. Think of these as important signals to contact your provider right away, just to be safe. A sudden gush of fluid from the vagina, that could mean your membranes have ruptured, your water broke.
Okay, that's a clear one.
Any vaginal bleeding. It could be related to the placenta, like placental abruption or previa, or maybe just the bloody show near labor, but it always needs to be checked out. Abdominal pain, especially if it's persistent, rhythmic, or severe, could be premature labor, could be placental abruption. needs assessment.
Right.
A temperature over 101 degrees Fahrenheit, about 38.3 Celsius, that usually points to an infection somewhere. Persistent, severe vomiting where you really can't keep anything down, that could be hyperemesis gravidarum. Then there are signs often related to high blood pressure or preeclampsia. Things like visual disturbances, blurry vision, spots, flashing lights. Also, sudden edema or swelling, especially in your face or hands. A severe headache that doesn't go away. Or pain in your upper abdomen, sort of under the ribs on the right side. Epigastric pain.
Those all sound serious.
They need prompt evaluation, yes. Also, painful urination or dysuria, as we said, could be a UTI, needs treatment. And finally, a noticeable decrease in fetal movement compared to the baby's usual pattern. That's always a reason to call, as it could indicate the baby is under stress.
Well, that's a really helpful list to keep in mind.
Yeah.
As the pregnancy progresses, you mentioned new tests become necessary. What new lab tests typically pop up later in the journey, and what are they looking for?
Right, the testing evolves. We continue with routine, clean catch urine samples at each visit, still checking for glucose, protein, signs of infection like nitrates or leukocytes. Abnormal results might point towards developing gestational diabetes, gestational hypertension, or preeclampsia, or a UTI.
So urine checks are constant.
Pretty much. Hemoglobin levels are also assessed regularly, often monthly, mainly to watch for that iron deficiency anemia. Normal levels drop a bit in pregnancy, but if it goes below 12 GDL, we'll usually start with nutritional counseling. If it's below 11, iron supplementation is typically recommended.
And you mentioned taking iron with vitamin C.
Yes, often on an empty stomach with vitamin C, like orange juice, helps with absorption. Around 35 to 37 weeks, there's a really important routine screen for Group B streptococcus, or GBS.
Okay, what's that?
GBS is actually a common bacteria found in the vagina or rectum of many healthy women. It's normal flora. But if you're positive and it's present during labor, the baby can pick it up during passage through the birth canal, and it can cause serious infection like neonatal sepsis.
Wow.
So if the screen is positive, we simply give you IV antibiotics during labor to prevent transmission to the baby. It's a very effective preventative measure.
That's great to know.
Then, usually between 24 and 28 weeks, comes the glucose tolerance test, GTT, to screen for gestational diabetes. You'll drink a 50-gram sugary drink, and we check your blood sugar an hour later. If the level is above a certain threshold, usually 140 milli-GDL, that's considered abnormal or a positive screen.
And what happens then?
That usually means you'll need a follow-up, longer test, the 3-hour GTT. For that one, you fast beforehand, drink a 100-gram glucose load, and we check your blood sugar multiple times over 3 hours. That gives a definitive diagnosis.
Okay, a two-step process potentially.
Often, yes. There's also an optional screen, usually offered around 15 to 21 weeks, called the quadruple screen or quad screen. It measures 4 substances in your blood: AFP, HCG, UE, and inhibin A. The levels of these markers can suggest an increased risk for certain conditions.
Like what?
For example, elevated AFP, alpha-fetoprotein, might suggest an increased risk for neural tube defects, like spina bifida. This really underscores why taking folic acid before conception and in early pregnancy is so important for prevention.
Right, folic acid is key.
Conversely, low AFP, along with changes in the other markers, might suggest an increased risk for chromosomal conditions like Down syndrome, trisomy 21, or trisomy 18.
Okay, but you mentioned it's optional and has limitations.
Yes, crucially, it's just a screen, not a diagnosis, and it has a relatively high false positive rate, meaning it can indicate an increased risk when everything is actually fine.
So it can cause unnecessary worry.
It can. If the results are abnormal, the next steps are usually discussing options like repeating the test, having a detailed ultrasound to look for markers, or considering diagnostic tests like amniocentesis for a definitive answer.
Got it. Screens suggest risk, diagnostics give answers.
Exactly. And we also continue screening for sexually transmitted infections, STIs, as needed. Sometimes this is repeated in the 3rd trimester, even if you were negative initially, especially if there are risk factors. STIs, even asymptomatic ones, can sometimes lead to early labor or cause infections in the newborn. So we screen for things like HPV. HIV routine testing is recommended for everyone, often repeated before 36 weeks if initially negative. Also syphilis, gonorrhea, and chlamydia.
And treatments are available during pregnancy for many of these.
Yes, for many bacterial STIs like syphilis, gonorrhea, and chlamydia, treatment, often with antibiotics like penicillin G for syphilis or others for gonorrhea chlamydia, is crucial to prevent transmission to the baby. And for gonorrhea and chlamydia, babies routinely receive erythromycin eye ointment right after birth as prevention against eye infections.
That raises an important point you touched on earlier. Why are certain tests done at specific times? And why is it so vital to understand the limits of screens like the quad screen?
That's a great question. The timing is all about getting the most accurate and relevant information at the right developmental stage. GBS screening is late because the result closest to delivery is most predictive. The GTT is timed when insulin resistance typically increases in pregnancy. And understanding the limits of screens, like the quad screen's false positive rate, is crucial for managing expectations and anxiety. It allows for informed decision-making about follow-up. We don't want tests to cause more stress than necessary. It's about balancing the benefit of the information against potential downsides like anxiety or the risks of more invasive follow-up tests.
That makes perfect sense. It's about optimizing information safely. Sometimes, though, to get an even clearer picture, we need more advanced tools, what allows us to actually peek inside the womb. Ultrasound seems like the main one.
Absolutely. Ultrasound is the cornerstone of fetal imaging. It uses sound waves, so it's very safe. There are two main types. Transvaginal ultrasound is often used in the first trimester. A small probe is inserted into the vagina. This gives really clear images of the early developing fetus, helps confirm the due date accurately, checks for the number of babies, assesses pelvic anatomy, and screens for early anomalies.
And the advantage is clearer pictures early on.
Yes, and you don't usually need a full bladder, which is a plus. The downside is some people might find it a bit embarrassing or uncomfortable. Then there's the abdominal ultrasound, which is probably more familiar to most people. The transducer is moved over your abdomen. This is used throughout the rest of the pregnancy.
Yep.
It helps us check fetal viability, the number of babies, their position, confirm gestational age, track the growth pattern, measure the amount of amniotic fluid, see the placental location and check its maturity, and generally assess fetal well-being. The main disadvantage is that it often works best with a full bladder, especially earlier on, which can be uncomfortable.
What kind of specific findings can ultrasound give us?
A whole range. We confirm viability by detecting the fetal heartbeat, which is usually possible around 6 to 7 weeks. We establish gestational age very accurately in the first trimester, usually before 12 weeks, by measuring things like the gestational sac, the crown rump length, head to bottom, biparietal diameter, head width, and femur length, thigh bone.
So dating is most accurate early.
Yes, definitely. Later on, ultrasound is used for the biophysical profile, BPP. This is usually done after 23, 24 weeks and assesses fetal well-being. It's like a fetal checkup. We look at 5 criteria: the fetal heart rate response, like an NST, which we'll discuss, gross body movements, fetal tone, like flexing, fetal breathing movements, practice breathing, and the amount of amniotic fluid. Each gets a score of 0 to. A total score out of 10 helps determine if the pregnancy should continue or if intervention might be needed.
Wow, a score for well-being.
Exactly. And Doppler flow studies are another type of ultrasound. They non-invasively measure blood flow, usually in the umbilical cord or fetal brain vessels. This tells us about placental function and resistance. It's particularly useful for monitoring babies with intrauterine growth restriction, IUGR, and can be done as early as 16, 18 weeks sometimes.
So beyond just seeing the baby, ultrasound gives functional information too. But what about assessing the baby's response to stress or movement directly? What about those fetal heart monitoring tests?
Right, those look at the heart rate patterns. The main ones are the non-stress test, NST, and the contraction stress test, CST. The non-stress test, NST, is very common, usually done after 23, 24 weeks. It assesses how the baby's heart rate responds to its own movements. You lie down with monitors on your belly measuring the heart rate and any contractions.
Okay.
The advantage is it's non-invasive and can be done as an outpatient. The disadvantage is it can have a high false positive rate, meaning it might look abnormal just because the baby is asleep, or due to medications or fetal immaturity.
So what's a normal result?
A reactive NST is normal. For babies over 32 weeks, this generally means at least 2 heart rate accelerations, speed-ups, of a certain size and duration within a 20-minute period. The criteria are slightly different for babies under 32 weeks. A non-reactive NST means these criteria aren't met, usually after monitoring for about 40 minutes, and it typically requires further testing, like a BPP.
Got it. Reactive good, non-reactive, needs more info. What about the CST?
The contraction stress test, CST, is a bit more involved and usually done in the hospital. It assesses how the fetus handles uterine contractions, basically evaluating if the placenta can supply enough oxygen during the stress of contractions. It helps predict if a fetus can tolerate labor.
When would you do a CST?
Indications might include concerns like IUGR, diabetes, being past your due date post dates, a non-reactive NSD, or a low BPP score.
Hmm.
There are contraindications too, like third trimester bleeding or a previous C-section with a classical uterine incision.
And what are you looking for?
We induce mild contractions, either with nipple stimulation or IV oxytocin, and watch the fetal heart rate. A negative CST is reassuring. It means no significant, concerning decelerations, slowdowns, of the heart rate occurred with the contractions. A positive CST is not reassuring. It means late decelerations occurred with 50% or more of the contractions, suggesting the baby might not tolerate labor well. There's also an equivocal result if there are some concerning signs, but not meeting the criteria for positive.
Okay, so CST is a more direct test of labor tolerance. Sometimes, though, even more specialized tests are needed, maybe for genetic insights or checking lung maturity. What are amniocentesis and chorionic villus sampling?
Right, these are more invasive diagnostic tests, usually offered when there's a specific indication or increased risk identified through screening. Amniocentesis involves inserting a thin needle through the abdomen into the uterus to withdraw a small amount of amniotic fluid surrounding the baby.
And what's that fluid used for?
Several things. It's often done between 15-21 weeks for prenatal diagnosis of genetic disorders like Down syndrome or other congenital anomalies by analyzing fetal cells in the fluid. Later in pregnancy, it can be used to assess fetal lung maturity. We look at the ratio of certain lipids, the LS ratio, lecithin-sphingomyelin. A ratio of 2.1 or greater generally indicates mature lungs. For diabetic mothers, we often look for a 3.1 ratio or the presence of another substance called PG, phosphatidylglycerol.
Can't check for anything else.
Yes, it can also help diagnose fetal hemolytic disease, where maternal antibodies attack fetal red blood cells.
Are there risks?
There are small risks associated with the procedure, both for the mother, like hemorrhage, infection, labor, placental issues, fluid leakage, and for the fetus, including injury, infection, or even loss, though these complications are rare when done by experienced practitioners.
Okay. What about lung maturity specifically? Is there anything done to help that?
Yes, if preterm delivery is anticipated, a steroid medication called betamethasone is often given to the mother, usually 2 injections, 12 or 24 hours apart. This helps accelerate fetal lung maturation and surfactant production, improving that LS ratio. It can be given as early as 24-26 weeks sometimes.
Got it. And the other test you mentioned, CVS.
Right, chorionic villus sampling, CVS.
Ah.
This procedure collects a tiny tissue sample from the fetal portion of the placenta, the chorionic villi. This tissue contains the same genetic material as the fetus. Its main advantage is timing. It can be done much earlier than amniocentesis, typically between 10 and 13 weeks gestation.
So you get genetic information sooner.
Exactly. Results usually come back within 1-2 weeks. It's often offered to women over 35 due to the increased risk of Down syndrome or those with a history of genetic disorders or recurrent miscarriages.
Does CVS have similar risks to amnio?
The risks are broadly similar, including vaginal spotting, miscarriage, rupture of membranes, or infection. There was an earlier concern about limb anomalies if done before 10 weeks, but that risk is considered very low now when performed within the recommended time frame.
So if we connect this to the bigger picture, these advanced tests, amniocentesis and CVS, while they carry some small risks, they offer really crucial, definitive information, especially for genetic concerns, much earlier in the case of CVS.
Precisely. They allow for informed planning, preparation, and peace of mind, or making difficult decisions based on confirmed diagnoses rather than just screening results.
Okay, shifting gears a bit. Beyond all the medical tests and monitoring, what else helps parents prepare for the actual event of childbirth and the huge life changes ahead?
Childbirth education is absolutely key here. The main goal is really to facilitate optimal decision-making by providing information and skills. There are often classes tailored for different groups too, not just first-time parents, but maybe refresher courses, classes for grandparents, siblings, adolescents expecting, or even specific classes for those anticipating a C-section.
So it's about knowledge and preparation.
Yes, and practical preparation too. For instance, regular exercise is highly encouraged, assuming no contraindications. Aiming for at least 3 times a week is great. The benefits are numerous. Better muscle tone, improved bowel function, potentially fewer complications during labor and delivery, faster recovery.
What kind of exercises are good?
Things that support the changes of pregnancy. Pelvic tilts are great for backache. Partial sit-ups can help maintain abdominal tone. Kegel exercises are crucial for pelvic floor strength, helping with delivery and preventing issues like incontinence later. And gentle stretches, like inner thigh stretches, can improve flexibility for labor.
Kegels, always important.
Always. And childbirth education classes often structure topics by trimester. In the first trimester, the focus is usually on understanding the physical and psychosocial changes happening, self-care basics, how to protect and nurture the fetus, choosing a care provider and birth setting, and managing those common early pregnancy discomforts.
Makes sense. Getting oriented.
In the second trimester, topics might shift towards planning for breastfeeding, discussing sexuality during pregnancy, and coping with later pregnancy discomforts as the body changes more dramatically. And in the third trimester, it's all about preparation for childbirth itself, developing a birth plan, learning and practicing relaxation techniques, coping strategies for labor, postpartum self-care, and even infant care basics like feeding and stimulation. It's really about anticipatory guidance, knowing what to expect each step of the way.
That structure sounds incredibly helpful. You mentioned managing discomforts. Let's talk about those common aches and pains. What are some practical ways to manage them? They seem almost universal.
They really are quite common. Managing them can make a big difference in comfort levels. For early pregnancy issues, heartburn is a frequent one. Eating smaller, more frequent meals helps. Avoiding spicy or greasy foods, not lying down immediately after eating, and using low-sodium antacids if needed can provide relief.
Okay, small meals for heartburn.
Constipation. Increasing fluids and dietary fiber, regular exercise, establishing regular bowel habits, and maybe using stool softeners if necessary. Hemorrhoids. Best managed by preventing constipation in the first place. But if they occur, topical anesthetics, ice packs, warm sink baths can help soothe them. Sometimes they need to be gently reinserted. Backache. Good body mechanics are key lifting properly. Pelvic tilt exercises help a lot. Avoiding high heels, heavy lifting, and getting overtired is also important.
Good posture saves the day.
It really does. Then in late pregnancy, other things pop up. Leg cramps, often at night. Actively dorsiflexing the foot, pulling toes up during the cramp helps. Applying heat can too. Sometimes evaluating the calcium to phosphorus ratio in the diet is considered. Varicose veins. Elevating the legs frequently, wearing support hose, avoiding crossing legs or wearing restrictive clothing, and avoiding long periods of standing can minimize them. Ankle edema, swelling. Some swelling is expected, especially at the end of the day. Frequent dorsiflexion of the feet when sitting helps circulation. Avoiding prolonged standing and elevating the legs is beneficial. However, sudden or severe swelling, especially with other symptoms like headache or visual changes, needs immediate attention as it could be preeclampsia.
Right. Differentiate normal swelling from warning signs.
Exactly. Faintness. This can happen due to blood pressure changes. Arising slowly from sitting or lying down, avoiding prolonged standing in one spot, and making sure hemoglobin hematocrit levels are adequate, addressing any anemia, can prevent it. And lastly, flatulence. Avoiding known gas-forming foods, chewing food thoroughly, maintaining regular bowel habits helps reduce embarrassing gas.
That's a great practical guide to managing the common stuff. So as we start to wrap up this deep dive, let's clarify some of the essential concepts and terms people will definitely encounter. What does all this mean in practical terms?
Okay, let's break down some key terms. First, your estimated date of birth, EDB, or estimated date of confinement, EDC, the due date. The most common way to estimate this is using Nagel's rule.
Nagel's rule, right. How does that work?
You take the first day of the woman's last menstrual period, LMP, subtract 3 months, and then add 7 days.
Okay, LMP minus 3 months plus 7 days.
Exactly. Its accuracy depends on a few things, though. Remembering the LMP accurately, having fairly regular 28-day cycles, and not having been on oral contraceptives recently, as that can affect cycle regularity. Ultrasound dating in the first trimester is generally considered more accurate if there's uncertainty.
Good point. Then there are those terms, gravida and para.
Yes, gravida and para. These describe pregnancy history. Gravida refers to the total number of times a woman has been pregnant, including the current pregnancy, regardless of the outcome. Para refers to the number of births, deliveries that occurred after 20 weeks of gestation, whether the baby was born alive or stillborn. Importantly, twins or triplets count as one para, one delivery event.
Ah, okay. One delivery event.
Sometimes it's broken down further using the GTPL system, which gives more detail. G is gravida, total pregnancies. T is term births, deliveries at 37 weeks or later. P is preterm births, deliveries between 20 and 37 weeks. A is abortions, pregnancies ending before 20 weeks, either spontaneous miscarriage or induced. L is living children, the number of children currently living.
GTPL got it. That's much more detailed. What about recognizing pregnancy itself? Signs and symptoms.
Right. They're categorized into 3 groups: presumptive, probable, and positive. Knowing the difference is important. Presumptive signs are the things the woman experiences or reports that suggest pregnancy but could be due to other things. This includes amenorrhea, missing a period, nausea and vomiting, fatigue, urinary frequency, breast changes, tenderness, enlargement, and quickening, that first feeling of fetal movement.
So things she feels.
Yes. Probable signs are those detected by the examiner during a physical exam that make pregnancy likely but still aren't 100% definitive. Examples include Hagar's sign, softening of the lower uterus, McDonald's sign, ease in flexing the uterus, abdominal enlargement, pigmentation changes like stretch marks, striae, the mask of pregnancy, cloasma, the dark line down the abdomen, linea nigra, and ballottement, feeling the fetus rebound when tapped.
Things the doctor finds.
Exactly. And finally, positive signs are the absolute objective proof of pregnancy. There are only three. One, hearing the fetal heartbeat via Doppler, fetoscope, or electronic monitor. Two, fetal movement that is felt or palpated by the examiner. Three, visualization of the fetus by ultrasound.
Okay, so only those three are definite proof.
Correct. Everything else suggests pregnancy but isn't conclusive on its own.
That's a crucial distinction. Briefly, what about nutritional needs?
Generally, an additional 300 calories per day is recommended during pregnancy for someone starting at a healthy weight. Weight gain recommendations vary based on pre-pregnancy body mass index, BMI. For someone underweight, BMI 18.5 gaining 28-40 pounds is suggested. Healthy weight, BMI 18.5 24.9, about 25-35 pounds. Overweight, BMI 25 29.9, 15-25 pounds.
Yeah.
And for obese, BMI 30 plus, about 11-20 pounds. Factors like maternal age, teens might need more, and parity also play a role.
Good guidelines. And lastly, any key physiological changes people should be aware of?
Oh, the body goes through amazing changes. In the reproductive system, the cervix softens, Goodell's sign, and can take on a bluish color due to increased blood flow, Chadwick's sign. The breasts enlarge and may start producing colostrum, a thin yellowish fluid rich in protein and antibodies, which is the precursor to milk. In the cardiovascular system, blood volume increases significantly. One thing to be aware of is supine hypotensive syndrome. When a pregnant person lies flat on their back in later pregnancy, the heavy uterus can compress the vena cava, a major vein returning blood to the heart.
What does that feel like?
Symptoms include feeling faint, dizzy, pallor, clammy skin. It's easily prevented by positioning on the left side or placing a small pillow under the right hip to tilt the uterus off the vena cava.
Left side lying. Got it.
And integumentary skin changes are common. Cloasma, those brownish patches on the face, mask of pregnancy, often worsened by sun exposure. Linea nigra, that dark line from the belly button down. And striae gravidarum stretch marks, which can appear on the abdomen, breasts, hips.
Wow. What an incredible journey we've covered today. Seriously, from that super comprehensive first prenatal visit through the whole schedule of ongoing care, those crucial tests, both screening and diagnostic, right through to understanding the amazing physical changes and how to prepare for parenthood. We really hope this deep dive provides you, our listeners, with a helpful shortcut to understanding the complex, sometimes confusing, but ultimately fascinating world of prenatal care, hopefully helping you feel truly well-informed without all the overwhelm. So as you reflect on all of this information, maybe think about this. What's one question this deep dive has sparked for you about the incredible adaptability of the human body during pregnancy? Or perhaps about how science continues to refine our understanding of something so ancient, so fundamental, and so profound as bringing new life into the world? We encourage you to keep asking those questions and continue your own explorations into the topics that pique your curiosity. Thanks for joining us on the deep dive.